Welcome to the Science of Sports Performance, where we discuss the real science of nutrition and exercise, helping you train smarter, fuel better, and perform at your very best. My name is Ben Pressler, and I'm currently an undergraduate student at Brigham Young University, majoring in both nutritional and exercise sciences. I'm pursuing my PhD with the goal of becoming a professor of sports nutrition. Today's guest is Dr. Sam Scott. Dr. Scott earned his PhD in exercise physiology at Liverpool John Moores University in the United Kingdom, with a research emphasis in athletes living with type 1 diabetes and continuous blood glucose monitoring. Dr. Scott has published more than 30 papers on the topic. For 5 years, he was the head of research for the professional cycling team Novo Nordisk, which is a cycling team comprised entirely of athletes living with type 1 diabetes. He is the co-author of the book Empowered, The Science of Exercise with Type 1 Diabetes. He is now living in Switzerland, where he is the CEO of the company Enhanced, which is a medical technology company that seeks to help people with type 1 diabetes interpret and take actionable steps based on the results from continuous glucose monitoring systems. In our conversation today, we discuss tools and knowledge that all athletes living with type 1 diabetes should have. But I believe it will be a very interesting conversation, even for those listeners who do not live with type 1 diabetes. We discuss a huge range of topics, including the physiology of the pancreas and how it creates and uses insulin in the body. We discuss glucagon as well. We discuss fueling practices for these athletes. We discuss a number of the complexities and the nuances of using insulin and the challenges that these athletes face. We also discuss some interesting topics like, do athletes need to be wary of the amount of adrenalin is released in their body due to the stress and anticipation of a sporting event, as well as whether or not insulin can be used as a performance-enhancing drug, and if athletes with type 1 diabetes have any sort of a performance advantage for that reason. Dr. Scott is a brilliant guy. He knows a lot about these topics, and he does a really, really good job of explaining these topics at a level that you can understand, as well as doing his best to give actionable tools, but also understanding that there is a lot of nuance and specificity into these topics. It was a terrific conversation, and I'm sure that you're going to enjoy it as well. Dr. Scott, or Sam, as you've let me know I can call you, thank you so much for being here on the Science of Sports Performance.
Thanks for having me, Ben.
Of course, I'm excited for our conversation today, and thank you so much for reaching out to me. I'm excited to learn all about your expertise in this field of tools for athletes with diabetes. And for all of our listeners listening today, that's something that Dr. Scott has already taught me, is there's kind of a shift we're trying to make, hopefully making in the nomenclature, is that rather than calling these athletes diabetic athletes, rather they are athletes living with diabetes. So I'm going to do my best to keep up with that nomenclature throughout our conversation today, but just for all you listeners who can take that away as well. But I wanted to start just by getting sort of a base level foundation of knowledge about diabetes as much as we can. Hopefully those who are interested in this episode have a certain understanding. But first off, would you just clarify my understanding of type 1 diabetes versus type 2 diabetes? Those are also known as insulin-dependent diabetes mellitus and non-insulin-dependent diabetes mellitus. So to my understanding, type 1 diabetes is an autoimmune disease where the insulin-producing cells of the pancreas have been destroyed by the body. So the body does not produce any insulin, whereas type 2 diabetes, the body can still produce its own insulin, but rather the body's cells are not receptive to the signal of insulin in carbohydrate uptake. Is that correct? Is there anything you'd add?
Yeah, it's basically correct. It's very, very close. So basically, diabetes as a whole is sort of an umbrella term, and then it's split into these different types, whereby the most common is type 1 diabetes, type 2 diabetes. Type 1 diabetes used to be called juvenile onset diabetes. Now it's no longer called that at all. Exactly as you say, it's an autoimmune condition whereby for some unknown reason, the body's immune system just attacks the cells in the pancreas and you no longer can produce insulin. Type 2 diabetes is this more chronic condition, develops over time, related to more lifestyle factors such as sedentary behavior, inactivity, lack of physical activity, higher carbohydrate diets, etc. And it basically leads to this situation where you're less responsive to the carbohydrates. So yeah, just what you said.
Right. And then, as you mentioned just now, it's common, for type 2 diabetes is a sort of a lifestyle disease, including being pretty sedentary. So I assume that in your work with athletes with diabetes, it's primarily those with type 1 diabetes. Is that correct?
So my work, I've been interested to basically help people to overcome the major barriers related to being physically active. This has included both people living with type 2 and type 1 diabetes.
Okay.
There are barriers that overlap between the two, such as very common things such as lack of time, lack of transport, lack of funds to have access to money. But then in addition, you have certain barriers that are specific to those living with each of these conditions. Type 1 diabetes, it's the fear of hypoglycemia, so that fear of low blood sugar levels. That's what I've been really trying to focus on. And then on the flip side, working with athletes living with type 1 diabetes predominantly. So how can we sort of really help people living with the condition to push what's possible in this space?
Wow, that's awesome, and I'm excited to get into that. Another question I had to start out is, what is HbA1c, or as most people probably hear it, just A1C? What is that exactly, and why are we concerned about it?
HbA1c is it's a way to give a measurement of average blood glucose levels over the last sort of 90 days. So what happens within the body is that the red blood cells, they sort of have glucose attached to them, and the higher the average glucose levels that you're experiencing, the higher this level of glycation will be with the red blood cells, and you're able to measure this to give an indication of whether the individual is experiencing higher than normal average blood glucose levels. So everyone has an HbA1c level. It's just that there's different sort of thresholds for what we would classify as sort of those who are experiencing higher glucose than normal, or those that are experiencing sort of more target range glucose levels. It's not perfect as a measure to indicate what our glucose levels are doing, because you can have a lower level of A1C, but you could experience a wide variety of glucose levels over that time. So it doesn't give the full picture, but it's a pretty easy, pretty cheap way to spot sort of where you are in your blood glucose levels.
Gotcha. So like anyone can kind of have like a blood sugar spike, and that could be just a fluke, but your A1C is kind of saying whether your blood sugar is like chronically high or if it's where it should be on average, right? Did I understand that correct?
Yeah, I think like as a parallel, I remember seeing a presentation where somebody said, because I lived in Toronto for a while, where they had really, really cold winters and really, really hot summers. And if you took the average temperature in Toronto, you'd say that it's very nice. But in reality, what you do by just taking the average is that you miss the highs and the lows.
Gotcha.
So HbA1c is very good to see what the average is doing, but you don't see the day-to-day fluctuations. So that's the kind of measure that it gives you, but the disadvantage that is associated with that.
That makes sense. Okay. In terms of those highs and lows, if an athlete has excessively high blood glucose or excessively low blood glucose, what are the dangers that those athletes are going to face when those highs and lows do occur?
Yeah, so in general, so speaking about type 1 diabetes, so the way in which you are physiologically is that you're basically trying to walk this tightrope of maintaining safe blood sugar levels, so kind of normal blood sugar levels. And the reason that you want to do this is that you need a little bit of glucose within the blood system, within the circulatory system, because this is really important for supplying energy to the brain. So if blood glucose levels go too low, you'll experience what's called hypoglycemia, low blood sugar levels. And this will lead to symptoms of associated with such as dizziness, lack of focus. Eventually, it will lead to very severe outcomes such as unconsciousness and could even lead to death if it's severe enough. On the other hand, higher blood sugar levels, so you don't want to have these too high. High blood sugar levels could indicate that you don't have enough insulin in the circulation, which will mean that your body is unable to metabolize carbohydrates, and then will seek other ways in which to get the energy. And this is where your body starts producing these, they're called ketones. So this will result in the blood becoming more acidic, and it leads to a situation called diabetic ketoacidosis. This is the sort of acute danger in that situation. But aside from that, you'll also feel pretty unwell. You'll feel quite sick, etc. So you don't want glucose levels to go high. Over a more longer term, you want to sort of avoid these higher blood sugar levels as much as possible, because it's associated with longer term risk towards complications, because high sugar levels is kind of toxic within the body. This is what the glucose is doing when it's at these higher levels. So this is where you get the damage within small blood vessels, like in the fingers, in the feet. You also experience problems in the small blood vessels of the kidneys, in the eyes, and this is where complications come in. So there's both an acute element to it and also a longer term element.
Gotcha. And then, so as you were talking about ketoacidosis, I mean, ketones, is a very sort of common idea in nutrition for those with diabetes and those without. If I understand correctly, ketones in and of themselves aren't necessarily dangerous. It's not the production of ketones that leads to acidosis, but rather, and this is me asking if this is correct, but is insulin responsible for your body using those ketones as well? Because to my understanding, the only reason that the elevated levels of ketones lead to acidosis is because your cells aren't able to take those up either. Is insulin responsible for the uptake of those ketones?
Insulin isn't responsible for the uptake of the ketones. Basically, it's the body is searching for an alternative way to supply energy. So ketones are a perfectly healthy part of normal metabolism. They're being produced all the time. They are increasingly produced by the body under situations of lower carbohydrate availability. This is because there's less insulin. And this can be positive because they're a very efficient way to access energy. The problem is when things become too extreme, on the other hand, when under conditions of type 1 diabetes where you don't have a supply of insulin at all. Perhaps you forgot to inject with insulin. Perhaps if you're using an insulin pump, there's a blockage on the catheter. This means basically the carbohydrates which are in the circulation, which are trying to get access to the muscles to provide energy, they just can't enter. So that's where the problem is. So it's basically sort of an imbalance And then the byproduct of that is the acidosis.
Gotcha. Okay. Well, thank you for clarifying my understanding there. You mentioned just now the administration of insulin and insulin pumps. Obviously insulin pumps are a wonderful, technology that we've come out for these athletes and these individuals living with type 1 diabetes. But just in terms of, subcutaneous administering your own insulin, how often, how many times a day is it common for those with diabetes to administer? And I guess I imagine there is, but is there a pretty big variance in how much each athlete needs? Like if there was someone that is the exact same height and weight as me, if I had type 1 diabetes and they had type 1 diabetes, is it likely that they might have pretty drastically different insulin needs than I would?
Yeah, so kind of maybe taking a step back. So the ways in which insulin is delivered, what this means, etc. So basically, if you're living with type 1 diabetes, your body's no longer producing its own insulin, and therefore you have to take over the job of doing that as sort of a human being who's got to sort of make decisions related to what your glucose is doing at a given moment, the way in which it's trending, so what you anticipate this is going to be moving into, in response to various factors going on in your life, whether it's a meal that you've consumed, whether it's physical activity that you're doing, these different things. And there's two ways in which insulin is delivered, and this will depend on the individual's preference and also what they have availability to in terms of health insurance, etc. So the first way is through multiple daily injections. So these are just basically injections where what you will want to do is administer. It's a little bit more complicated than this actually. So you have what's called your background or basal insulin, and then you have your bolus insulin. So you'll probably administer what's called basal insulin once or twice a day, depending on the dynamics of the particular insulin that you're doing and your individual needs. So this is long-lasting insulin that acts in the background.
Gotcha.
And then the bolus insulin is given at certain moments to either cover the carbohydrates in a meal, or because your blood glucose is on the higher side, so that you can take in the glucose from the bloodstream into the muscles or the adipose tissue.
Okay.
So these are injections, and then the other side of things is the insulin pump. So the insulin pump is a device. It's a small little thing, like probably some of them are quite small now, like the size of a mobile phone, or maybe like even like 2/3 of that, or half the size of that. Now there's a few different types, but just generally speaking, that's what they're like. They attach to a catheter, so a long wire, and then it basically drip feeds insulin into your system. So you don't need to do this basal bolus system. It's just sort of dripping. And as a user, you can adjust the amount of insulin that is coming through. So if you're about to consume a meal, you can increase the rate at which insulin is being administered, or if you're about to do exercise, you might decide to what's called suspend or turn off the pump at that moment so that it no longer releases insulin.
Gotcha.
There's more complex and increasingly common ways in which these are used now. We have what's called is kind of the artificial pancreas, which you might have heard of, or hybrid closed loop systems. Basically, what this is a system that is able to make decisions by receiving information from a continuous glucose monitor. It has an algorithm that is therefore able to adjust your insulin automatically based on rate of change of glucose or other varying factors that are put in. And related to the question that you said about how often you have to do these things, how much it varies from person to person, it really depends. It depends based on your level of insulin sensitivity. It depends on other factors such as your lifestyle, etc.
Gotcha.
So it's not really possible to give like an amount, so to speak, but there are certain instances whereby the amount that you're administering might change. So if
Yeah,
you
that makes sense.
experience a period where your insulin sensitivity increases, such as if you do a lot of physical activity over a couple of days, then you will need to reduce the insulin that you're
Huh.
administering. So this is how it will change. Or if you have a day with quite a lot more carbohydrates than you're normally accustomed to, then you will increase the amount of insulin that you're administering.
Yeah, that just kind of is crazy to me, just like the complexity of the human body and how really awesome it is. Like you're describing all these things, these continuous glucose monitors, and the artificial pancreas that these companies are, I assume spending millions of dollars to make and to program and to put these complex algorithms in them. But then those without diabetes just kind of live with an organ inside their stomach that, or not obviously inside their stomach, but inside their abdomen that just knows how to do it all the time, which I think is pretty incredible. The last question I had for you is just, is there any other way for carbohydrates to enter the cell than insulin? Or is that it?
Yeah. So this is what's so interesting about exercise in particular, because you have two major pathways that cause this. So basically, glucose will enter the bloodstream after you've consumed a meal. The role that or the aim that you want to have within the body is that you want to maintain this normal blood sugar level in response to a meal. This is assuming that you do not have diabetes. Your pancreas will release insulin. The insulin will act on receptors at different tissues that take up glucose, such as adipose tissues, such as skeletal muscle. This will cause glucose receptors to move to the muscle membrane so that glucose can enter and then is either used for fuel or it is stored in some capacity. So in the case of skeletal muscle, it will be entering and then used, or it will be entering and then stored as glycogen. Interestingly, exercise also, or muscle contractions more specifically, act to do a similar thing whereby there are pathways within skeletal muscle that are activated when your muscles contract. So when you start moving, these pathways are independent of the insulin sensitive pathways, which means that if you live with type 1 diabetes, they are kept intact. It means that muscle contractions, they cause the glucose to be taken up and you can use it as fuel. These pathways are also additive as well. So this is where additional problems may come into play, whereby if you administer insulin close before an exercise session, you're going to have both the insulin dependent and the muscle contraction stimulated pathways acting at the same time. And this is where you get quite rapid declines in glucose. And this is where people experience hypoglycemia.
Yeah, gotcha. That makes a lot of sense, actually. Thank you. I think, I at the very least now kind of have some good understanding to, I don't know, just set the tone for our conversation today. Tell me a little bit first about your experience working with athletes with diabetes. You don't have diabetes yourself. It's just a research interest for you, a work interest. But how long have you worked with athletes with diabetes across what types of sports? What are the common challenges that you've seen these athletes face?
Yeah, so this is quite a big question. So my sort of interest in this area goes back. I've been working in this area maybe around 10 years now. When I first started out doing my PhD, this was split into two main focuses, I would say. One was very much kind of taking muscle biopsy samples, studying them under the microscope to really try and explore how the muscle was adapting, following different exercise interventions, what was going on in this in this field. And I thought originally that this was the path that I wanted to take post PhD and then go off and work in that area. But the interest for me started because I was doing these lab-based studies where we were looking at different interventions around blood glucose management in people living with type 1 diabetes. And I was having to spend a lot of time with people in the lab who were taking part in these studies over 6 weeks, 12 weeks. I was seeing them sort of 3 times a week and building up these relationships in person. And as you say, I don't live with type 1 diabetes, but this experience provided quite a small window, I would say, into just how frustrating, complicated, difficult it can be doing any level of exercise when living with type 1 diabetes. I mean, I was only sort of experiencing the small window of when participants would come in. We'd be trying to do maybe 30 minutes of cycling on the bike.
Yeah.
But sometimes we would have to cancel sessions because participants had experienced hyperglycemia beforehand. It was common that people would experience hypos during the cycling, etc. And this really highlighted to me, speaking to people in this area, learning more about the condition, that more needed to be done in this area, that there was very little that was known, despite there had been work in this area, but I still felt that there was not information reaching people. So after the PhD, I decided this is what I want to do all of the time, learn what's going on, try and produce different kind of findings that can be translated into real life for people. And then I was also interested because I had seen examples of professional athletes living with type 1 diabetes. I really wanted to learn how they were doing what they were doing so that I could translate that into the different experiences that I was having in the clinics. And I was fortunate enough to be able to be in positions where I've worked both with professional level athletes. I've worked for professional cycling teams, really spending a lot of time of what happens when you're doing extreme endurance events. I've worked with team sports athletes, which is completely different demands, all kinds of things, and seeing that it's definitely possible to compete at any level with type 1 diabetes, but it's still super complicated. And I still think that there's a lot that needs to be done to translate this to regular people and also translate this back to clinicians to assist them in turn to assist the patients that they're working with. And then the other thing from a completely sidestepped point of view is that I was working quite closely with a lot of sports scientists who were really focused on how do we get the most out of professional athletes that we're working with? How do we get that extra 0.1%? And there's a lot of training principles, sports nutrition protocols, etc., that are very common in athletes who do not have diabetes. And I was fascinated by the idea of how so many of these concepts are so reliant on the hormone insulin, and how if this is completely knocked out, as it is in type 1 diabetes, that the decisions that you have to make in order to manage glucose levels safely, but then look to incorporate some of these principles into training, recovery, competition, I think is super interesting. So I think it's really interesting if you're somebody who is not really focused on diabetes at all, who's somebody who's a sports nutritionist, sports scientist, because it gives you that appreciation of how much of a sort of focus that key hormone is. But if you're living with type 1 diabetes, I think it's interesting because you can look to incorporate these things into your life. And then also clinicians, how do we help more people become active? How do we remove those barriers as part of exercise? So that's basically me and my interests.
That's super, super cool. What would you say, I mean, if you had an athlete with type 1 diabetes, I mean, remember I went to high school with some athletes who had diabetes, and I mean, just because they're living with that illness doesn't mean they're any different or they're not interested in sports or activity and things like that. So obviously I assume that there have been many athletes living with diabetes who try and engage in exercise or engage in sports, and they just don't have perhaps the knowledge to manage their blood glucose levels properly and things, just because, I mean, maybe they don't know better. But what are some common mistakes or some common, I mean, I feel bad calling it a mistake. I don't want to call it a mistake, but what are some common, I don't know the best word for it, accidents or whatever that these athletes might do that leads to them getting hypoglycemia or hyperglycemia or anything like that? What are some common mishaps, I guess I should say, that these athletes face that you might correct if you could?
I think there's quite a few. So I think that the first thing is that type 1 diabetes is a condition that is very kind of hidden. There's no real identifier for this. So the person living with the condition, there's no way in which they stand out particularly in that format. I mean, nowadays there's increasingly numbers of people who are wearing continuous glucose monitors, and you will see these sensors sometimes. But aside from that, and what the main reason for highlighting that is that it's also a condition that you're very much likely to feel alone. And this is what a lot of people who live with type 1 diabetes say, is that they feel very alone in the number of additional decisions that they make, the external sort of understanding that people have of the condition. And this is why these support groups that exist are so essential. A lot of people living with type 1 diabetes will actively seek out others living with the condition because of the fact that it's almost impossible for somebody who doesn't live with a condition to really understand what it's like. I mean, I've been working in this area for years, but I know that I do not fully have that appreciation of it because it's just not possible to really reach that level there. I think also within the general population is that type 1 diabetes is quite a complicated condition. There's all kinds of concepts which you wouldn't normally come across, and why would you? So I think it's quite understandable that people don't really understand things such as insulin, normal glucose levels, what that would mean for the individual living with the condition. So I think that that's also why it's important to have the conversation, have the education, etc. In terms of like the other sort of misconceptions there's probably lots that I will miss off. And people who are listening to this, if you're living with type 1 diabetes, will probably sort of be shouting that there's a big list. But some is that you commonly hear things such as like, is that the bad type of diabetes, or is that the good one? Is that the one that's or that type 1, is that the first one that then leads to type 2 diabetes? That's not the case. They're two completely separate conditions. There's misconceptions that people cannot do exercise. There's misconceptions that people cannot consume sugar or eat sugary meals, etc. This is not true either. So there's lots of different things such as that. And so, I mean, if there's somebody that you're working with who's like an athlete, like if you're a coach, etc., I think it's sort of a lot of people who live with type 1 diabetes, from my experience, are very open to speaking about it because they're very keen for more people to sort of understand how it is to live with the condition and share more information about how it is for them.
Yeah, wow. That's awesome. And I mean, I am, even in our conversation now, just kind of beginning to know how much I don't know and how much there is to know. So I'm sure there are, if anyone living with type 1 diabetes is listening to this conversation, probably things running through their head and questions they have and things that they've heard from, friends and family members and classmates that seem kind of silly. I mean, I think I work as an EMT firefighter, so diabetes is kind of something that we might run on if someone is hypo or hyperglycemic, or especially if they're acidotic. And so, I mean, walking into a conversation like this, I already even think, I kind of have a decent understanding of these conditions. And, well, I'm learning that I don't. So I guess my point in saying that is that we probably need to have quite a bit of empathy for these people and the challenges that they face, because I'm sure there's a lot that we do take for granted.
The decisions is the other thing. So it's estimated that somebody living with type 1 diabetes has 200 additional decisions every single day. Wow. So when you think of, like, I'll give you a scenario. For example, if we are we're having this conversation, or we go for dinner together and there's a group of people, we're having an in-depth conversation, and then you get asked the question of whether you want something to drink or whether you want something to eat. You've got to sort of be thinking about what you're going to order, thinking about the timing at which that meal is likely to arrive, then the insulin that you have to administer, which has to be timed a little bit in advance of where you expect the food to come, because there's sort of that action, the peak of action time will come into play sort of 10 to 15 minutes later. And then your meal is delayed by half an hour. So then you're sort of looking for bread or something. All of the time, there's a complex conversation going on, and you're trying not to lose track of the thread of that. This is just a very small insight into that. And then we go outside, and then you wanted to catch a bus or a taxi, and it's run off without you. So you've got to run after it. The spontaneous physical activity that will come into play if that happened, and how all of these factors are going to be influencing your blood glucose levels while you're trying to contend with everything else that goes on in life.
Yeah, it's incredible. I couldn't imagine. And I guess hats off to everyone who's living with that. I mean, even like if I go out to a restaurant or I'm with a group of people, I try and be conscious of what I eat, right? For health's sake and for nutrition's sake, but I don't have to think about the way it applies to my physiology. I don't have to think about whether my exercise is going to affect my health negatively in the acute sense. So that is pretty incredible. I'd love to have a discussion with you now about just aspects of sports nutrition. It's something you've kind of already touched on with the athletes that you have worked with, and how we can apply principles that most people use that maybe these athletes can or cannot use. So I'd love to just talk about, some of the common practices and common ideas in the realm of sports nutrition, and I'd just bounce them off of you and tell me how these might be different for athletes living with type 1 diabetes. Things that they need to consider, and so on. I think probably one of the most obvious ideas is that of carbohydrate consumption during exercise. And obviously every single sport requires energy, carbohydrates are commonly going to be the preferred or the most efficient, I should say, source of fuel in the body. But I really do love kind of talking about cycling, which is good because I know you've worked with a lot of cyclers, just because I feel like it's a good example of something that could be like really drawn out endurance exercise, or it could be, there's like sprint cycling where it's a lot more high intensity and things like that. But we know that a very common guideline is to consume 60 grams of carbohydrates per hour. So I guess like a gram a minute of physical training. And that's not just for sports performance, like on the day of competition, I mean to say, but that is even during your training, because, the better fueled you are to train, the better capacity you have to increase, the capacity of your heart and lungs. And so you should fuel during your training. You should fuel on race day. If you're going on a 2-hour endurance bike ride, for example, you should probably consume about 120 grams of carbs during that bike ride so that you can maintain peak performance as best as you possibly can. If there were athletes, I guess, living with type 1 diabetes who prefer to maybe eat a lower carbohydrate diet and have a higher fat diet, I've never necessarily heard a recommendation for fat intake. And then, of course, I wouldn't know anything about the optimum amount of insulin to take, or if you'd even need to take insulin, because you said the exercise can open those sort of glucose transporters. So if I was exercising while I consume carbs, would I need insulin at all? What do we think?
There's a lot of things to unwrap there. So like maybe we can focus on cycling, because cycling is a good sport, because cycling is a sport that you really have to get your nutrition right. It's a sport that a lot of the scientific literature is focused on just generally, because most sports science studies are done related to cycling in terms of looking at fueling, optimizing of that, because the sport is so reliant on getting these things right. It's so reliant on getting different aspects of your training right. So cycling is a good one. So there's lots of different things. I mean, when we're talking with type 1 diabetes, regardless of what sport you're doing, the most important thing is that you need to manage your glucose levels safely. So you need to ensure that you're avoiding hypoglycemia. If you experience hypoglycemia during a race, aside from it being dangerous, sort of from a health perspective, your competitiveness within that given race is basically zero. You're not really going to recover from that. You're not going to get back. It's just too. There's just no way that you'll be able to cope or be able to recover and be in a competitive state. So, I mean, there's all kinds of different things we could talk about in terms of like, if we're looking at fueling during a competitive race. So during a competitive race, yeah, you're right. You'll want to have predominantly carbohydrates. Your main thing that you're thinking about if you are an athlete who does not have type 1 diabetes is, how do I consume enough carbs to cover the work that I'm doing?
Right.
And in general, to hit those high levels of carbohydrates that you require, our bodies are not able to use or be able to take on just glucose. And this is why, if you look at different sport supplements, they tend to be a combination of different types of carbohydrates. And there's in the cycling world, there's commonly this sort of 2-to-1 ratio of like 2 parts glucose, 1 part fructose. It's simplified in that manner for sort of marketing reasons, but there's a specific function behind that. I mean, it can get more complex in that there are different nuances, there are different formulations that are done, but like sort of starting from a more simplistic reason. And the reason that's there is because glucose and normally fructose, which is part of this, they are metabolized differently. So they're absorbed through different transporters within the stomach, which allows you to have a like a greater sort of absorption of carbohydrates in order to have more carbohydrates that are being entering into the body that can be used and oxidized for fuel.
Real quick, sorry, I don't mean to cut you off, but I mean, first of all, for all our listeners, sucrose or table sugar is a disaccharide of glucose and fructose. So if you just consume sucrose, you'd be having a 1-to-1 ratio of glucose and fructose, right? I wonder, just because glucose, obviously, when that disaccharide is broken apart into the glucose and the glucose is ready to go. It's ready to be used by the body, whereas the fructose has to go through the fructolysis process in the liver. So is it, I guess, almost like kind of a shorter acting source of energy? Like if you consume sucrose, then you'd kind of get a quick hit of energy from the glucose in it, and then like a slightly delayed from the fructose, because it has to be metabolized by the liver before it can be used for fuel. So it kind of stretches it out a little longer.
Yeah, well, so as well, you're probably seeing like the glycemic index of these different sugars. This is the way that it is. So the glucose, this is just going straight into, absorbed by the gut, going straight into the bloodstream. Whereas if it's in an other format, such as if it's combined with something else, in the case of sucrose, this is going to have an extra step for metabolism, so it's going to be slightly slower. So this is why you'd want to have something that contains just glucose, and then the fructose is going to be metabolized through the liver. This has got a lower glycemic index, so it doesn't have as much of an impact on the blood sugar levels, and it's being metabolized that way. And this is important for sort of being able to meet energy needs. But thinking about the conversation in the context of type 1 diabetes, it's important to recognize that those different sugars will have a different impact on your blood glucose concentration at that time. So you will need to administer insulin in a slightly different way according to the different combinations of sugars that are coming into the body. You're going to also be able to, if you're kind of really thinking about it, manipulate which particular sugar that you're taking on at that point, depending on where your blood glucose levels are. So if your glucose levels are on the higher end, you might choose to avoid glucose and then just have fructose, so that you're able to meet more your energy needs while reducing the sharper spikes in glucose. It's going to take a lot of trial and error, this sort of complexities within that, but it's mostly just to illustrate that these different factors are in play, and there's really little sort of research specifically in type 1 diabetes that is related to this.
I'd like to take a quick break and thank the sponsors of today's episode. Now, unfortunately, I'm kidding. I do not actually have any sponsors. Rather, I put on this podcast with my own time and my own money as a part of my desire to spread high-quality information about nutrition and exercise science. It's a passion of mine, and it's something that I love to do. If you would like to help this podcast out and become a sponsor in your own little way, there are some terrific zero-cost ways that you can support today's episode. The first is to like this episode on YouTube or wherever you listen. You can also subscribe to the show on YouTube and follow the show on Apple and Spotify. You can also, on Apple and Spotify podcasts, leave the show or the episode up to a 5-star review. You can also put any comments with questions or content suggestions that you have in the comment section on YouTube, or you can share this episode directly with somebody who you think might enjoy it. I do also offer nutrition and exercise coaching if that is something that you are interested in. That is a for-cost option and a way to support this podcast. If that is something you're interested in, you can find my information in the show notes. One thing that I've been thinking about as you're talking, especially, about your blood glucose level, is that most people, I was under the impression for a long, long time that, the human body just has like a ton of blood in it, but it's really not quite as much as many people think. It, like, an average adult has like 6 liters of blood in our body, which is not what I thought it was going to be, like 20 liters or something. But then I'd say like an average healthy blood sugar level would be like 100 milligrams per deciliter. And I kind of say that because it's within average range and it's easy math. But it's measured, you'll see it in millimoles per liter in like the scientific literature, but usually if you're just using like a glucometer or something, it's going to be in milligrams per deciliter. So if you had 100 milligrams of glucose per deciliter of blood, and you had about 60 deciliters of blood because you have 6 liters of blood, then that's only 6 grams of total glucose in your bloodstream. And so obviously 6 grams of glucose is 24 calories. And we burn 24 calories pretty quick during exercise. So I guess it makes me think of the hormone glucagon, which is the opposite of insulin. Whereas insulin is to deliver sugar in the blood to the cells of the body, glucagon lets the cells of the body break down glucose and release it into the bloodstream. Do athletes with type 1 diabetes have the ability to produce glucagon to control that if their blood sugar goes down pretty quick? Because I do know that it's common for those with type 1 diabetes to carry like a glucagon rescue pen. But at the same time, I know that glucagon is made by the alpha cells in the pancreas, whereas insulin is made by the beta cells in the pancreas. So tell me about that glucagon and the regulation of, like, if you were hypoglycemic, are athletes going to be able to recover from that pretty quickly with the help of glucagon?
Yeah, I mean, there's, again, quite a few different concepts that you've covered there, which are really good. You're right. The amount of sugar or glucose in the bloodstream at any time is incredibly low. This sort of teaspoon worth of sugar, this sort of 5 or 6 grams in the circulation, and it is a very little amount. And you think about how much we stress the system by often consuming very high carbohydrate meals, etc. So how the body has to cope with that, and at the same time within exercise, the fuel requirements to take glucose in to be able to meet the energy needs, ensure that the brain has enough access to glucose to maintain normal functioning. And you're right. There's this balance between these hormones in order to ensure that this normal level is remain in check. So the reason for so there are a few things there. So in terms of whether someone with type 1 diabetes produces glucagon, there is some evidence that this can be slightly impaired, but it does seem as though people with type 1 diabetes still produce this hormone. One problem is that in order to release glucagon, insulin levels need to be sort of reduced. And in normal physiology, when you don't live with type 1 diabetes, when you start exercising, for example, and your body realizes that there's muscle contractions going on, I don't need so much insulin in the circulation, the half-life of that endogenous insulin is much, much faster than even the really fast-acting exogenous types of insulin. So if you have injected insulin exogenously, this insulin doesn't break down in the body so quick, so it impairs the ability of the body to be able to release the hormone glucagon, which would act on the liver normally to release glucose to sort of maintain that level. So that's a big problem that can come into play as well.
Huh.
And then the
That's
second
good to
thing that
know.
yeah, I mean, these are the different things which are complicated. There's a lot of things which are complicated, and this is where I think the conversation sort of risks getting where you get muddled and missing different things, and this is where diabetes is extremely complicated. But one
Yeah.
aspect is the fact that under normal physiology, your body, your circulatory system is not really exposed to that high insulin levels ever really, because insulin is released from the pancreas through the portal vein and then is passing through the liver. The liver is sort of acting as a sort of first sort of screening process before the insulin then enters the circulation. However, if you live with type 1 diabetes, you are administering the insulin subcutaneously, which means that
Gotcha.
it doesn't pass through the insulin through the liver
Oh,
first. It's actually
yeah.
going directly into the circulatory system. So it means that you're just exposed to this higher level of insulin, and this is where you also get issues where the amount of insulin in the circulatory system does not match what is seen in normal physiology. So this balance with glucagon there gets sort of impaired in a way. So you have longer half-life combined with the fact that it's greater exposure, and these two things mean that that's why it's more complex to manage. And then what you mentioned was the like pen, the glucagon emergency pen that people commonly carry. So the reason for this is that your liver has this store of glucose in the form of glycogen. Glucagon is the hormone that causes this glycogen to be rapidly broken down to supply glucose.
Gotcha.
So if you're experiencing really low glucose levels, you're experiencing hyperglycemia, you have this glucagon pen, which releases glucagon very rapidly, acts on the liver, and causes glucose to be released, and so will raise glucose levels. That's what it's for.
That makes
so
sense.
it's there as a like an emergency rescue. Probably what's most common is that if you're in that situation, it would have to be administered by somebody else.
Gotcha. Is glucagon then, does it primarily work on the glycogen stores in the liver and not in the muscle cells?
Yeah.
Okay, good to know. I'd love to talk to you and get your opinion as well about the different levels of carbohydrates we can consume in our diet. Usually, and these terms are kind of, they don't really have a scientific consensus on what these terms mean, but terms like a very low carbohydrate diet versus a low carbohydrate diet, or a moderate carbohydrate diet, or a high carbohydrate diet, I think there's sort of general ideas, but it's never really been nailed down what these things are. To me, and again, I've never worked with or coached an athlete with diabetes, and frankly, if an athlete with diabetes came to me and asked for my help with their nutrition coaching, I would probably turn them away and tell them no, because I would be worried that I would give them advice that was not suited for them, and I wouldn't want to take that responsibility for their health in that way. But for all the athletes that I have worked with and that I do work with, I consider a very low carbohydrate diet basically no carbohydrates at all. Ketogenic is my opinion on what a very low carbohydrate diet is. And usually what that means is less than 25 or less than 50 grams a day. And usually that's coming from like vegetables, like broccoli and stuff. If you're having good servings of vegetables, you'll probably get 25 grams of carbs in a day. A low carbohydrate diet, again, in my head, is probably like 120 grams of carbohydrate a day, just because I know that is kind of considered the RDA for carbohydrates, because that's how much the human brain likes to use in a day, is about 120 grams of carbs. So at that point, you're fueling your brain with carbohydrates, but maybe not so your physical activity. A moderate carbohydrate diet could be 200 grams to 400 grams, but then when you get into moderate and high, it's probably better to define it on grams per kilograms of body weight rather than an absolute number. And then a high carbohydrate diet, to me, is about like 8 to 10 grams of carbs per kilogram of body weight that you weigh. What do you think about those levels that I've thrown out there? Do you kind of agree with that? Do athletes living with diabetes need to be especially like mindful of that? Like if you're trying to carb load or get ready for your race day, for example, and you wanted to consume that high carbohydrate diet to to carb load, right, and make sure that your glycogen stores are all the way full and ready to go for race day. Is that, like, could that be super, super dangerous? Like, you could lead to hyperglycemia or...
Yeah, I mean, well,
That was
this
a mouthful. I apologize.
yeah, this is no, it's good. This is a big area, and I spend quite a lot of time thinking about this in terms of how it fits in socially, how it fits in within sports, in terms of sports performance, different considerations related to training and adaptation, weight management. And we wrote a paper on this a while ago because I was interested in different factors related to sort of the history of carbohydrate intake, low carbohydrate diets, and how they relate to type 1 diabetes, and how those types of diets have evolved and progressed in society. Also, what's possible, what's the potential positives or perhaps negatives of following one of these diets, what is actually meant by following one of these diets in terms of, as you say, what would the composition of your meal actually look like if you were aiming to have one of these different carbohydrate diets. And there's different classifications. We also, within that paper, we tried to put together some examples of very low carbohydrate diets and what that would mean in terms of, were you even able to meet different micro and macronutrient requirements in terms of, like, it's a very, very low amount of carbohydrate, and whether you're even able to meet fiber requirements if you are not consuming fruits or vegetables that contain carbohydrates as well. The definitions are sometimes blurred between different things. And then also there's a lot of people who are super passionate about this. They say that this is the best thing that they do. There are also people who don't want to incorporate that. There's, I think, pretty clear evidence that within the realm of endurance sports, such as professional cycling, professional running, that carbohydrate is king, that in order to compete at that level, you absolutely need to be maintaining a carbohydrate diet that is going to allow you to be sort of really maxing that out. But there's nuances within your training, which means that certain pathways can be sort of hit in a certain way at specific or key training sessions that lead to certain metabolic adaptations. You might incorporate lower or restrictive carbohydrate diets at specific points of the season to manage fat mass or your weight in general.
Yeah, true.
It depends on the type of sport that you're doing, whether you're in a sport that relies on cutting weight, etc. There's so many complexities related to this. And I think it's also that there are examples of people who've done really extreme levels of sports on low carbohydrate, restricted carbohydrate diets. I think the human body is amazing in that it's able to cope with a lot. So
Yeah.
it's certainly possible to do these things. Whether it's optimal, I'm not so sure. So it depends really on the individual, where they are, what their preferences are, etc. But it's a huge topic, and there's lots of interesting concepts and particular aspects which I think are particularly sort of interesting to focus on when we speak about type 1 diabetes and sports.
Wow. Yeah. And just to kind of go off one thing you said in all the complexities of this, right? Sometimes people will come to me and they'll ask me, usually it's like a friend or a family member, and kind of ask me for like a very blanketed piece of nutrition advice. They're like, what should I eat? It's like, well, what do you like? What are you allergic to? What are your needs? How much do you exercise? What's your budget? And yeah, just to highlight the fact that it's very, very challenging, if not impossible, to give a very, very blanketed, this is what you need to do. As you've talked about, like, what sport do you do? What are the body composition requirements for that sport, right? What's, like, if you're a wrestler, what's your weight class? And I mean, all these different things. So I appreciate you trying to shed light on all these topics, but to all those who are listening, I guess, that hope that maybe we're going to get to the point where we say this is exactly what you ought to do, that point of this episode is never coming. We're going to try and give you as many tools as we can, but we're not going to be able to nail something down exactly for you.
Mm-hmm.
One thing I've have been taught as an EMT is that things like epinephrine or adrenaline, when you have a release of that in your body, that can lead to an increase in your blood glucose levels. Other things like cortisol and things like all these different hormones can have an effect on that. But I wanted to highlight epinephrine or adrenaline specifically because I know that, again, depending on the sport for sure, but I think for most athletes, when you're at this time of competition, this time of, perhaps a little bit of like anxiety about your competition and excitement, you're going to have this release of adrenaline. And that can be good in a lot of ways, but I wonder if that release of adrenaline is perhaps going to be something that could be potentially harmful for these athletes. Like, is that going to cause such a change in your blood glucose levels that it's beneficial for these athletes to try and kind of manage their stress levels and their adrenaline levels at competition? And
mm-hmm. Yeah, it's huge. It's huge. Adrenaline acts on the liver to cause this release of glucose, and so you can get very high spikes in blood glucose levels. For an athlete living with type 1 diabetes, this will depend on your susceptibility to stress. It will depend on how you, because some athletes are super chilled at the beginning of competitive events. Some people get really, really stressed out. And so this makes it difficult to simulate exactly an approach to handle a competitive event. I mean, the way in which that's going to be managed is through experience, on top of trying to come up with perhaps some ways in which you might manage that stress. So how you might sort of cope with that, whether it's more kind of psychology related factors. So if you are at the beginning of the starting line, or you're at the beginning of a match that you're about to play, other athletes who don't have type 1 diabetes are just thinking about, okay, what's my fueling in the lead up? What's going on here? But the stress is causing this high glucose levels. And speaking to athletes in this situation, you're then left with a decision of, do I administer more insulin at this point to lower my glucose levels? But the problem is, at that point of starting the event, the adrenaline is going to go down then, but you're also going to have the contractions from when you've actually started doing the physical activity, and your blood glucose is likely to go down. and so you're putting yourself at risk of hypos within the first sort of half hour of whatever event that you're doing. So it's extremely challenging, and we do see this quite often.
Huh. Yeah. I mean, I guess that all makes sense to me. And it kind of goes into another thought or question that I had is perhaps some hidden challenges that these athletes face. You know, obviously when we're thinking about what do these athletes have to think about and be concerned about in terms of their sports performance, we're thinking about carbohydrates, we're thinking about fueling, we're thinking about insulin. But are these athletes going to be especially susceptible to anything like their hydration and their electrolyte levels? Or what about like taking caffeine is a very, very common practice because that's, you know, kind of performance enhancing. Is that a consideration they need to make there? Is there anything else? I guess the question that I'm trying to get across is that is there anything else that I take for granted as an athlete without diabetes that for those athletes living with diabetes have to be aware of, or else they could run into these performance detriments?
Yeah, I mean, I think the reason I'm smiling is because I think the better question would be, is there anything that is not going to greatly impact their behaviors? So I think to simply answer the question, every single factor that you can think of related to nutrition, related to environment, related to emotional stress, like competition-related stress, anxiety, and that side of things, related to the level of insulin sensitivity according to changes in your body weight that you may have experienced due to where you are in competition, is going to be different. I mean, hydration is, and level of dehydration is going to change depending on your blood glucose concentration. So there's limited research in this area, but one of the problems of being, of having higher levels of glucose is that you're going to experience dehydration faster. You're going to you're going to need to go to the toilet more often. Like things like caffeine, as you say, this is going to influence your glucose. We did some studies looking at this. A lot of sports supplements commonly include that. Every single thing, basically. Intensity of the exercise, whether you experienced hyperglycemia the day before, whether you trained the day before, the altitude, the cold temperatures, the hot temperatures, everything.
Wow. Yeah. Okay. That definitely makes sense as an answer, and what it just keeps making me think of is a question that I was planning on saving for a little later, but I just feel like it's so fitting right here, is that of insulin as a performance enhancing drug, a PED. Some people get a misconception about that because insulin can be used as a PED. I think less commonly in endurance sports, but I think where most people get that idea, not that it can't be used as a PED in endurance sports, but is because bodybuilders, like open bodybuilders, these gigantic dudes, in addition to all the anabolics that they take to grow their muscles, it's common for them to take insulin just because they're eating such high volumes of food. And so people kind of get this idea that insulin is always a performance enhancing drug. And they will think that, if an athlete is living with type 1 diabetes and they have to rely on insulin, they get this, I'm going to go ahead at this point in our conversation and say that they get this sort of ignorant view that insulin gives these athletes a performance enhancing advantage, this insulin use. And I think we've done nothing in this conversation today that has not shown us that that's not the case. Insulin is not, I think people just think that it's this balance of just two things. You're balancing your insulin, you're balancing your blood glucose, and that's it. But you've gone ahead and shown us that that's not the case at all. Like everything can impact your blood glucose, and if something impacts your blood glucose when you meant for exogenous insulin to impact your blood glucose, then you're going to be hypoglycemic and your performance is going to go down. And so I think just that, like, it would be impossible for an athlete with type 1 diabetes to manage their insulin use so well that it became performance enhancing. Would you agree? What's your stance on that topic?
Um, so we um, Simon and I we wrote a book recently about type 1 diabetes and exercise, and one of the chapters that we featured there was around this idea of, and we posed the question within this particular chapter of, could an athlete living with type 1 diabetes theoretically have any advantage? And this is a sort of a conversation that we put forward that's potentially contentious. It has to be handled in the right way. It has to be sort of looked at this from the point of view that it's important that you're managing these topics very well. But it was also an interesting topic from sort of an academic standpoint to just ask, because, as you say, one of the things is insulin. There are reports that some people have been using this, recreational athletes, professional athletes. It's a banned substance outside of type 1 diabetes.
Mm-hmm.
And the reason that they might do this is because there's these like reported anabolic or anti-catabolic pathways that it might increase, and therefore would help with gaining muscle mass, would potentially help with recovery. And so we started exploring that. We started exploring whether that could be something that needs to be taken into consideration. And the first thing, as you rightly highlight, is that like there's so many things going on with type 1 diabetes, those 200 additional decisions, but that by far it overweighs any positive impact. But we started looking at this sort of thing, and like based on what we could find within the literature, looking at where the evidence had come related to that, we sort of concluded that this does not seem to be the case at all.
Yeah.
So any evidence that sort of suggests that there is a sort of benefit physiologically in terms of gaining mass has been, or this evidence has come from studies that are completely non-physiologic, which have either been done in cells or have been done in animal models, whereby you've basically given a completely supra-physiological level of insulin or amino acids at the same time, which do not reflect normal physiology and would just not be achievable. Combined with that, the fact that it's really not the smartest thing in the world to do is to start messing around with insulin if you don't know what you're doing, because the risk of hyperglycemia is a real one. And then also we started looking at this more so in terms of like, okay, what would that mean? And so basically breaking down the way that muscle protein synthesis works is that you have these pathways. So muscle protein synthesis, muscle protein breakdown are basically these two elements involved in normal breakdown and buildup of muscle. And these are happening in cycles. This is part of normal physiology. And there are certain stimuli which are either environmental or from within the body, which include things related to nutrition or exercise or disease, which impact these two processes.
Yeah.
And these two things are important to be happening in the right balance. And it's a really easy thing to assume that having the on switch on all the time would be beneficial. So you might assume that sort of always having muscle protein synthesis on go all the time and just turning off that breakdown would be the best possible way to build up muscle. But the breakdown is also a super important element towards having optimal physiology of skeletal muscle, because it's important that the broken down proteins, the proteins that need to be removed, are also being taken away to build up. So there needs to be this time whereby the synthesis isn't there. So even assuming that administering more insulin would somehow impact these factors, we could only see a way whereby this might actually be potentially detrimental, because if you are inhibiting those catabolic process, if you're inhibiting the muscle protein breakdown, you might not be able to sort of remove those damaged proteins, and it could actually be detrimental. So based on what we could find, I mean, no studies have specifically looked at this, but based on this thought experiment that we started putting together, we can't see a benefit here.
Yeah. I mean, if you get rid of that, catabolic system, it's like the waste disposal system. Like if you get rid of a waste disposal system in anything, right? If you as a human can't relieve yourself in the bathroom, if a city doesn't have their garbage and waste disposal system, like that, it's pretty easy to imagine how that could lead to some pretty bad outcomes. And as you've mentioned, you said insulin is pro-anabolic. I wanted to, for all our listeners, just kind of define those two words, anabolic and catabolic, and anabolism and catabolism, because a lot of people have just heard the word anabolic as it relates to anabolic steroids. And so a lot of people think that the word anabolic means like muscular or something. And that's not the case at all. But all anabolic means is the creation of new cells. And all catabolic means is the breakdown of existing cells. And so, yes, like creating new muscle cells, increasing your musculature, that is anabolic. But anabolism, it's just the creation of cells. So if you're getting fat, if you're putting on fat mass on your body, that is the anabolism of fat tissue. And same with catabolism, right? Catabolism is just the breakdown of anything. It could be the breakdown of, organ cells. Heaven forbid, it could be the breakdown of muscle cells or of fat cells or anything. And so the fact that insulin is anabolic doesn't just mean it makes you get bigger, stronger muscles. It just means that you're creating new cells, which I believe you mentioned in one of your papers. I wanted to ask you about it, that because insulin is pro-anabolic, can actually lead to the anabolism of fat tissue. It can lead to weight gain as a side effect. And I think you described it as a barrier to compliance, which I thought was a fitting way to describe it. But, if a side effect of taking insulin to manage your diabetes is that you gain weight and you put on additional fat mass, I can definitely understand why that would be a barrier to compliance. Could you tell me just a little bit more about how that works? How is insulin, signaling to our body to just create new cells, fat cells in this case?
Yeah, I think there's a bit more of a sort of nuance to sort of clarify there. So the evidence that insulin is anabolic is not so strong. It's stronger that it's more anti-catabolic, so it can actually sort of interfere with those. I think with the paper that you're referring to, I think this is more around sort of decision making rather than on a cellular level or on a physiology level. And what I mean by that, I think, related to the paper that you're referencing, is more around people's decisions to adhere to perhaps diets whereby or having exercise. I think where this has come from is that one of the barriers to exercise is that some people don't want to consume the carbohydrates that may be associated with managing their glucose during those levels.
Okay.
And they find it more challenging to manage their weight. So one of the key ways in which someone living with type 1 diabetes avoids hyperglycemia is by needing to consume more carbohydrates.
Gotcha. Okay.
So under those situations, some individuals can see it as a real, I don't want to say annoyance because it's stronger than annoyance, but something that's really a barrier to that is that they get annoyed by the fact that they have to consume extra carbohydrates to manage their blood sugar levels.
That makes sense. That's a fitting clarification. That makes a lot of sense to me. And yeah, I guess the thing that comes to mind as you say that is that, for example, if you're an endurance athlete, a runner, or a cyclist, you should be consuming carbs to fuel that performance. Whereas a lot of people who, go on a morning run are doing it for the benefits of like weight loss. So they don't want to fuel their run. They want to use their own adipose tissue to fuel that run. And so I can definitely understand that distinction. Like if you took one of those athletes who's trying to maintain their body composition just by going on runs, and you said that you have to consume carbs or you're going to have these bad health outcomes, that could be, undesirable. So that makes sense.
Yeah, that's what I'm specifically relating to. It's like, for instance, someone not living with type 1 diabetes. If I want to go to the gym now, part of my goal is weight management, but I'm experiencing low blood sugar level of that. During that, my options are to reduce my insulin, but sometimes that's not enough. So I need to cover the session with carbohydrates.
Yeah, that makes sense.
This can be something that is like an additional sort of barrier to doing that sort of exercise, just because it's something that some people find frustrating.
Gotcha. Well, yeah, that makes sense to me. Thank you so much for explaining that to me. One thing, just as we're on the topic of some of the papers of yours that I read in preparation for today's conversation, I'm interested. Obviously, I think that like a ketogenic diet is appealing for these athletes living with diabetes because it wouldn't require, like if you were completely like strictly ketogenic, you wouldn't necessarily have to worry about your carbohydrate consumption so much and your blood glucose levels. And I'm sure that I'm not quite aware of how little that would lead to you monitoring that or anything, but I can assume that the ketogenic diet would be desirable. In one of the papers, I think it was like a review article about implications for athletes eating a low carbohydrate diet. You guys referenced a study that was done on, I think it was people in the military, males in the military, and they wanted to see a performance difference between a group that was consuming a low carbohydrate diet and a moderate carbohydrate diet. And obviously you didn't conduct this study. Maybe you haven't even like read it in like a long, long time, so you don't know quite what I'm talking about. But in this study, they basically found no significant difference in performance, which makes sense. I mean, I could imagine that in these athletes, especially that it's not like very low and high, but it's just like low and moderate. My question is, I believe perhaps that there's no performance difference, but I'm curious about RPE, or rating of perceived exertion, just because I've done a ketogenic diet like briefly. Usually it's for like trying to drop weight before like a powerlifting meet or something like that, and I just feel bad. Like if I'm trying to go to the gym, I don't feel like I have energy, and I usually can like take some caffeine and kind of push through it, but just like I feel slow and I feel weak and I feel fatigued. When your work with athletes living with diabetes, if they're trying to do a ketogenic diet for the sake of their health and their blood glucose level management, so they want to have this ketogenic diet, have you noticed that you just feel groggy, or is there any way to overcome that? Is there just a point of the ketosis that kind of goes away? I guess I'm curious about your fatigue levels on the ketogenic diet.
So I've never worked with an athlete who's doing a keto diet, because I mean, working with professional cyclists, working in different sports, this isn't something that generally a nutritionist would recommend in those types of situations. There are situations where you might want to implement a restricted carbohydrate diet, but the level of restriction is sort of relative, and it will depend based on what the individual is used to. It will depend on that different point, and it will also be very sort of specific in the time window. So, for example, there are different types of restricted carb diets where you're actually consuming a pretty high carbohydrate diet. So, for example, if you do fasted training, you're doing that particular exercise session in a fasted state, but after the session is finished, you might consume a breakfast, which contains plenty of carbohydrates. So there's sort of nuances in this sense. So, I mean, the experience that I have with ketogenic diets is mostly through speaking to people who are not athletes, just sort of anecdotally their experience. A lot of people who are on these say that it's great.
Right.
I'm not sure. I've never followed one myself, but I think it's a very individual thing that if it works for them, then it's fine for them.
Yeah, there you go. That makes sense. I guess kind of going off of that, you've kind of talked about like adjusting your carbohydrate intake, maybe perhaps lowering it relatively. I'm curious about the idea of training low. What is it? Training low, performing high. Is that what we called it? I wrote it on this page. Competing high. Training low, competing high in terms of your carbohydrates. That's a topic that came up in some of the papers. You and I discussed it briefly in planning for this episode. Tell me what that looks like. Is it something that, like myself as an athlete without diabetes, it sounds like it could be useful or beneficial for me? Is it something that athletes without diabetes could consider? What would you teach us about training low, competing high?
Yeah, so I mean, I don't think really anybody has looked at these questions specifically within type 1 diabetes in the way that we did. So a lot of this was based on different assumptions and sort of piecing together different puzzles. But I was working in a sports science institute where there was various studies going on, various applied sports nutritionists where they use these concepts on a regular basis with athletes without diabetes, because there's very clear evidence that there can be clear performance outcomes from deciding to implement these strategies depending on where the athlete is at the point of the season on their specific goals. So, for example, I think within the paper we outlined 3 or 4 types of restricted carb diets. So there's like fasted training, what's called sleep low, train low, or also twice per day training. And these different types of restricted training can be very beneficial. So like fasted training can be good, as it means you're doing like longer term or longer duration training sessions. They tend to hit metabolic pathways that can increase fat oxidation. It can be good for managing your weight in the off season. There's evidence that doing twice per day training is more effective than doing once per day training. Also, this the other reason is that you are training in the morning, for example, and then you're not replenishing your glycogen stores, and doing that second training session in a state of glycogen depletion is what leads to those greater metabolic adaptations. There's different protocols which are used. But I started thinking about, if you live with type 1 diabetes and you've also got to add in the complexity of managing your glucose, where does that fall into play? Because it's not so obvious as to how you might do a fasted exercise training session if you are trying to manage your glucose. But on the other hand, we were doing studies which demonstrated that actually fasted training could be beneficial for blood glucose management, because we did some studies that showed that if you don't consume carbohydrates and you don't have the insulin with that, if you just go out in the morning and then you just start doing a long bike ride, actually your glucose will be very, very stable. It could be beneficial from a weight management point of view. And so that could be a really good strategy that you might want to incorporate within your training. Same with some of these other strategies, but there were some of them where we just saw perhaps this is really complicated to do, such as the sleep low, train low, where
True.
basically you're training in the evening, then you are putting yourself in a situation where you're in a low glycogen or you're in a glycogen depleted state overnight. You're not refueling, and then you're training again in the morning. So for somebody living with type 1 diabetes, you could imagine that's very complicated to manage, perhaps, or it's just a little bit more risky. So there's different things such as this where athletes who do not live with type 1 diabetes, they're always looking for that extra 0.1% of how do they
Right.
manipulate their nutrition, how do they manipulate different training strategies to elicit those greater adaptations. But when you live with type 1 diabetes, how do you think about incorporating those strategies? What's the positives or perhaps benefits that can be gained by having the knowledge of how they could fit in?
Wow. Thank you for explaining all of these complexities. The knowledge that you have is pretty awesome. I look up to the work that you've done, and thank you for coming on. In finishing up here, we've talked a lot in this episode about just all the nuances and all the complexities and all the different contexts that this advice could be applied. So obviously, in one episode of a podcast, we're not going to get it all nailed down. You could do hours, and you could do 100 hours of podcasting about working with athletes who live with diabetes. But in finishing up, tell us if there is somebody listening to this episode who is very interested about the work that you do and the advice that you have. Obviously, you have your book, Empowered is the name of it. Is that right?
Yeah.
And it was co-authored between you and what's the name of your co-author?
Simon Helleputter. So Simon is a PhD from Belgium. He's been working in the space of type 1 diabetes and exercise.
Awesome. So that's a great resource for anyone interested in learning more about you and your work and the advice that you would give is that book, Empowered. I believe it's available on Amazon, right?
Yeah, I mean, it's exactly as you said. So this is a very complex topic, I would say, and it's very easy to sort of come in and out of different areas to it. So what we wanted to do with that book was try and produce something that was accessible for more people outside of kind of published literature. Also provide a resource where all of this information was in one place, because that just didn't exist. So
Gotcha.
as you say, yeah, it's available on Amazon, on Audible as well. We also did the audio book, but it's really about all of these things of what diabetes is and what it means if you're interested in sports.
Awesome. And then you also are the CEO of a company of this app called Enhanced.
Yeah.
I wanted to give you as much time as you feel like you need to talk about that app as well. To any listeners, it's not that Dr. Scott came on to advertise any of his stuff or to sponsor this podcast and to promote any of his stuff, but just I want to give you the time and the space to talk about that. Why did you make this app? What challenges are you hoping to help these athletes overcome, and what can they benefit from it?
Thanks. I mean, yeah, so the reason here is that, as we've discussed, living with type 1 diabetes is really complicated. Exercise is one of these factors which lots of people want to do, but it's extremely complex from a glucose management point of view. What we recognized was that a lot of people now have access to continuous glucose monitors.
Yeah.
But in terms of how to take action from the data that's being produced from that, there isn't a solution that exists. So we wanted to simplify the way in which your continuous glucose monitor is able to work with data from exercise wearables. And the app is available on the App Store. Check it out. We are actively improving it all the time. So stick with it. And yeah, we have some exciting plans to make that much better and really try to help in this complex problem.
That's awesome. That's awesome. Just kind of helping these athletes take actionable steps based on the data that they're getting, which they might not know how to do. My two final questions for this episode today are: what can athletes who do not have diabetes take away from our conversation and the principles we've talked about today? And then, do you have sort of a personal thesis statement? And perhaps thesis statement is too strong of a of wording to use, but if there's something that you really wish you could just shout on the rooftops to the whole world, like what's something that you wish everyone could understand, or at least all the athletes living with type 1 diabetes could understand?
I think I can answer both questions at the same time. So I think that this conversation is potentially interesting for, as I said before, I think both those living with diabetes and their clinicians, and then also those who don't but have an interest in exercise physiology or an athlete without diabetes. It's that appreciation that your body only has that teaspoon of sugar, as we discussed, and how if you're living with type 1 diabetes, just the complexities of self-managing that small window to keep glucose within a safe range, and how complex that is from a sports performance angle. And if you do not live with diabetes, you're not somebody who's impacted by this, just the appreciation of how much we take for granted of our physiology being able to manage this.
Yeah.
If you think about the sort of abuse we put our bodies under with the high carbohydrate intakes, with the complexities related to training intensities, those stress responses, etc. So I think it's basically the appreciation for how much insulin does and how impactful that is when insulin is not there.
Wow. Yeah, I'm coming to appreciate that in a very small way, and I'm sure that there's so much more to understand. Well, like I said, the knowledge that you have, the expertise and the experience that you have is incredible. Your desire to really help these athletes, that where you've seen this challenge, and you really are stepping in to try and provide these tools and the knowledge and the resources for these athletes to succeed. So it's been great having you on. Thank you so much for coming. I'd like to thank you guys as well for joining us on today's episode. If you'd like to learn more and hear more from Dr. Scott, he has done other podcasts on other platforms, as well as, of course, you can go and find his book, Empowered, The Science of Exercise with Type 1 Diabetes, as well as you can look for his app, Enhanced, on the App Store. If you are enjoying the things that you are learning and hearing on this podcast, again, there are some terrific ways that you can support this podcast. You can like, follow, subscribe to the show on YouTube or Apple or Spotify, wherever you listen. If you have any questions or comments or content suggestions, you can leave those in the comment section on YouTube. I do read all the comments. Guys, I know that these are things that every YouTuber, every podcaster is going to ask you to do, and I know it can get repetitive and annoying. I empathize with that, and I understand, but really, these things do help this podcast grow and help it reach more people who would be interested in this content, so I'm grateful for you guys who would take the time to do that. Thank you for joining us. This has been The Science of Sports Performance.